Dear pure urology viewers, good evening one and all. Today topic is very common topic, very interesting also because in the recent past in the pure urology we are covering mostly supine PCNL, ECARS and RARS. As prone PCNL is the standard and worldwide practiced most often. Again, it's better to listen from a person who is interested in endourology and who is trained in a place where prone PCNL is taught in a best manner. That is Dr. Gopal Tak. So we will introduce Gopal, and he is presenting today on basics of prone PCNL, how I do. Dr. Gopal Tak is MBBS, MS, DNB Urology, currently working as consultant at Asian Institute of Nephrology and Urology Hospital, Ainu, Hyderabad, Telangana. And that is in our area. MNAMS, member of National Academy of Medical Science. He is a World Endourology Society recognized fellowship in endourology, laparoscopy, and robotic surgery at Muljibai Patel Urology Hospital, Nadiad, Gujarat, India. He had completed a DNB urology training from MPUH from March 2015 to 2018. That means his post MCH is around 6 years. He has subspecialty interest endourology, laparoscopy, robotic surgery. He has 20 publications to his credit in reputed peer-reviewed national and international journals. He had authored 4 book chapters and editor of the ADPKD book, reviewer of various international journals, 24 national and 7 international presentations. With this introduction, Gopal, I wish you take time, don't be in hurry,
Sure,
because whenever you talk and teach, please remember the first few years of private practitioners, not your contemporaries, because they are the ones who will be having lot of doubts. If this continues, this education continues, because every year 300 urologists will come. All may not have adequate training during their DNB and MCH training.
Yes.
It is you and me who can help them, and they will be happy to understand the minor points. So
Yes.
don't rush. Take
Yeah.
45 minutes minimum time, and then communicate properly the prone PCNL, which you are very experienced. Thank
Yes.
you. Thank you.
Yeah. So at the outset, I would like to thank Dr. Chandramohan sir for opportunity on giving me to talk on the pure urology. I'll start sharing.
Yes, you are shared the screen.
So coming to the basics of the prone PCNL, the prone PCNL is the most commonly done surgery for stones when I was in Nadiad, and this was the more commonly done rather than RIS. But after shifting to Hyderabad, now RIS has taken the RIS has already won the race, and majority of time we are doing RIS now. So I have seen many people who are coming visiting to the INU or in Nadiad. They are not confident or not well trained in the PCNL or specifically prone PCNL. Some people have not seen even prone PCNL also because their consultants are in the learning phase of prone PCNL. So coming to the basic, starting from the anatomy, as you know, so the kidney is lying onto the sauce and is lying 30-degree to the coronal plane, so that the posterior calyces, they are oriented in such a that the posterior calyces are oriented into the towards the broader line, and we assume to puncture through the posterior calyces will be the leading to the avascular area. So when you have the CT, you just rotate the CT from upside down and see that where is the posterior part, how the kidneys are there, where is the colonic shadow, and where is the psoas muscle. So basically, the calyces, they are oriented like the lower calyces, they have anterior and posterior calyx, but the upper calyces, they have medial and lateral. So this is very important landmark paper by Sampaio, which has shown that the orientation of calyces, and so that this will help in proper puncture and avoiding the complications like bleeding, which is the many people are feared of. That bleeding is the major complication. Because of that, people stop doing PCNL. So the orientation and the proper anatomical knowledge of the calyces in coming with respect to the lower calyx, middle calyx, and upper calyx is very important to avoid the complications. So as you know, so majority initially it was thought that what are the lateral calyces are the posterior calyces with respect to the lower pole. But later on, Hodgson found that the lateral calyces are the medial also, so which are common on the left side on the Hodgson kidney, and for the broad kidney is common on the right side. But irrespective of the site, what matters is the proper puncture is the matter. Coming to the vasculature or calyceal orientation, now here you concentrate on the figure A. In the coronal view, there is a relative vascular areas which will lead to the renal calyceal puncture. And this coronal view between and parallel to the interlobal arteries, the calyces are in between the and parallel to the interlobal arteries. If you puncture that calyces which is posterior, then that is a safer and a vascular plane. Again, in the axial view, along the broader line between the anterior and posterior circulation, you can see the anteriorly, these are the vessels which are crossing, but here posteriorly is quite posterior. And this is the avascular plane and where the posterior calyx is lying. So if you target posterior calyx, the chances of the bleeding post PCNL is very less. So coming to the, I have trained in the Nadiad. We are more common. We usually do the lower calyx or middle calyx puncture so that we can access the majority of the lower calyx, middle calyx, and pelvis or upper ureter also. Unless the stone is in the upper calyx, we don't touch the upper calyx because the posterior segmental artery crossing to the infundibulum around 60% in the upper calyx, which the percentage goes down when it comes to the lower calyx. It is only 13% of the cases this segmental artery will cross the infundibulum. So what calyx we in lower calyx also there are the different like medial or lateral calyxes. So this study has shown that the most medial calyx in the two-dimensional is the first calyx, which is almost anteriorly facing. So if you start from clockwise direction, to see the calyceal anatomy from clockwise direction, the first calyx which you show in the CT scan or the IVP will be the medial calyx or the anterior calyx, and the second calyx will be the posterior calyx or lateral calyx. And our target is to do puncture in the second calyx, or which is the posterior or lateral calyx, which will reduce the infectious complication, the bleeding complication, and it will give direct path. You can see here from second calyx, it will give direct path to the infundibulum and pelvis as well as upper ureter also. Also, we can go to the some of the amount of the middle and upper calyx also we can negotiate. But if you target the medial calyx or anterior calyx, this will be very difficult to negotiate to the infundibulum, pelvis, and upper ureter. So to remember that the second calyx, which is posterior or lateral facing, is the calyx of the entry. So what is important is not anterior posterior, the angle of entry through which the majority of the pelvic calyceal system is accessed is important. So coming the chances of retrorenal on the CT is only less than 1 to 10% in prone, and better to plan PCNL by CT films upside down so that we can see where is the colon, where is the saw shadow, and what is the window which we can get between the vertebra and the bowel area while doing the puncture. We should not see the kidney alone. We should see by this adjacent organ also. Like here, the puncture. Some people are feared of the pleural puncture because the parietal pleura is inserted at the 8th, 10th, and 12th intercostal space or rib in the mid-axial line, mid-clavicle line, mid-axial line, and posterior-axial line respectively. So during the puncture, especially for the supracostal puncture or upper calyceal puncture, we should remember where the insertion of the pleura is. Usually, if you do the puncture below 10th rib, then the chances of pleural injury are very less. Unless you go above 10th rib, the chances of pleural injury are high, and then that will lead to pneumothorax or hemothorax or the hydrothorax. So this is very important while doing the supracostal puncture. And there are various manuals by which we can avoid the supracostal puncture, so we can avoid this pneumothorax or hydrothorax complication. So coming to our topic, how I do PCNL, I like the general anesthesia is preferred, but we can do under spinal anesthesia or regional anesthesia if it is clinically indicated. Then we'll give lithotomy position. Then we'll place the ipsilateral ureteric catheter. Usually I place 5 French ureteric catheter. Then place the 14 or 16 French ureteric catheter and Foley's catheter, and then turn the patient prone. So while turning patient prone, there are certain important things we should remember. I have small video. I will just share you how the patient is turned. After here, the patient has been placed the 5 French ureteric catheter and Foley's catheter is placed. Now we are starting turning the patient prone. Now here, the anesthetist is holding the endotracheal tube in place. It is securing the airway first. Then the technician is putting a sliding pad below the patient, and with the sliding pad, this patient is shifted to the one trolley or shifting trolley. Now, once it has shifted, we are bringing this shifting trolley to the operating table closer, and then we are the opposite side technician are holding properly, and the technician which is ipsilateral side will push or will turn the patient to prone. At that time, this you can see here endotracheal tube we have disconnected. Immediately after prone, the patient is like immediately after prone, we are securing the endotracheal tube. We are connecting to the this ventilator. Now, once patient has turned to prone, patient has been turned prone, we have to secure his patient's arm. We have to pad. So with rotation, we are securing here the left side arm and right side arm also secured. Then anesthetist will auscultate properly whether we have like there is any problem in the breathing or the tube has been shifted. And here in the legs, you can see it is already padded. So pressure points has to be padded properly. So this is how we have to turn patient prone. So after turning prone, what techniques you can follow? Either ultrasound guided, fluoro guided, and I will be discussing about fluoro guided puncture, and that to be monoplanar, biplanar. In biplanar, you have a triangulation and bullseye technique. I am trained in the triangulation technique, so I will be discussing about the triangulation technique. So my disclaimer is that everyone has their own way of puncture. What I follow is the triangulation technique, and not what I follow. Everybody should follow it. This is the one easier for me, and I am following since long time. So I am practicing on this only. So this after patient positioning, this area is painted and draped from back to the upper thigh region. So this after painting and draping, the marking, surface marking is very important. So this surface marking includes the posterior axial line, then the lower two ribs, the iliac crest, and the lateral border of erector spine. So this is after painting and draping. So here you can clearly see the lower rib, the ipsilateral posterior axial line, iliac crest, lateral border of erector spine, and midline. So our target is to be just posterior to the posterior axial line so that it can find the straight path to the lower calyx or middle calyx or desired calyx what we are targeting. So this is the case we will discuss now. This is the pelvic stone, large pelvic stone. So after you see the large pelvic stone, you have to after doing the RGP, we mark the stone surface on the surface, and this will be the trajectory. This angle is very important. So this angle will be just below the 12th rib, starting from the 12th rib, below the 12th rib, and then that will direct in the straight line, so that it will the calyx, infundibulum, and pelvis should be in the same line or in the straight line. So once you direct on the surface, then you do small incision and start putting puncture needle. Now you can see in the fluoro image also. Now here we are puncturing. So once you think that we are over the calyx, we are reached the calyx, ask the assistant fluoro technician to turn the CM towards us or towards my side or towards surgeon side. You can see here, now we are rotating the C-arm towards us. See here. Now, shit. So after puncture, we are rotating CM. Now see the distance between the needle and the vertebra. You have to see once you think that you have punctured the calyx. Now this distance you have to compare when you turn the CM towards surgeon side or 30 degree towards us, so that if the distance goes down, that means the distance between the vertebra and the needle goes down, that means you are superficial and you have to go deep. So you can see here, after turning 30, the distance between the needle and vertebra has came down. That means you are superficial, and then you have to adjust, you have to bring the needle back and again go little deep. You can see on the surface view also, the trajectory of the needle looks like it is very superficial. This angle should be around 45 degree, around 45 to 50 degree towards the horizontal. So this appears to be more obtuse angle. So we need to withdraw the needle and go little deep. So you remember, if the distance between the needle and the vertebra after turning 30 comes down, or it reduces, or the needle comes closer to the vertebra, that means you are superficial and you have to go little down or deeper. Now again you turn to 0 degree, and then now you are now going little deeper. You can see the angle on the surface view, and we are puncturing, and we think that we are on the desired calyx. Now again we have turned the needle 30, and now see the distance between the needle and vertebra has increased. That means you have gone away from the vertebra. So naturally, if you are going away from the vertebra, means you are deeper. So you need to come superficial. So here the distance between the needle and vertebra has increased or it has gone up. Now we are again adjusting and putting into the calyx in between. So once you are in the calyx, just withdraw the needle and you can see the clear urine is coming. So once clear urine comes, we'll we place a guide wire. Usually because of stone, guide will not go into deep. And here I would like to tell, so once you have punctured and placed the guide wire, you incise with the knife the whatever there is in mind. Either you are putting Mini-perc sheath or ampla sheath. So that much amount of incision you should think and you should give on the skin when the needle is in the already placed. Otherwise, what will happen if you withdraw the needle and only over the guide wire you place the incision, then sometime guide wire may be damaged or sometime the incision will not be adequate. So this is the time we should give proper incision. Now here the guide rod we are placing after 12 French dilatation, and here we are placing the ampla sheath. I am following the single step dilatation. So after a guide wire, we'll put a 12 French or 14 French dilator, after that guide rod, and then ampla sheath. So this is the single step dilator. This will save the time, and a single step dilator what we are following, I'm just showing. So guide wire is placed, adequate incision is given, then guide rod is placed. Over the guide rod, the 24 or 26, whatever desired ampla sheath you place. Here see the rotating movements of our hand, and after that we place the sheath which is your desired. So once you withdraw once you are in on the fluoro, just withdraw the amplas dilator and ask the assistant to flush saline from below, and then you can see the clear urine or little blood tinge urine, and we are inside the system. So after this stone clearance with the help of lithoclast, or this is the big stone, so we have used lithoclast or shock pulse, and our exit strategy is to put a Foley, a 14 French Foley. So here is another example. You can see the upper aortic stone, large upper aortic stone, initially planned for RRS, then we convert into Mini-perc. So here again, surface marking of the desired calyx, you can see after contrast, as I told you, after contrast installation, whatever the calyx which you are seeing from in the clockwise as a first calyx, which will be the medial calyx or anterior calyx. Our target is to puncture posterior calyx, which is lateral calyx. So I am targeting the lateral calyx. You can see the surface marking. So after targeting, we give a small incision just below the 12th rib. And you can see we are just seeing the movement with which we are just directing the needle. Initially, we just around 45 degrees to the floor, we are putting the needle. And then we see the movement of the kidney, whether it is moving or not. Sometimes we are superficial, sometimes we are deep. So we need to adjust while going inside. And here after giving thrust, there will be movement of the kidney at the level of thoracolumbar fissure or the renal capsule, which we have to check while doing the monoplanar technique. So I am putting the needle inside and I have punctured. It appears that I have punctured the system. Now I will ask the assistant to turn CM 30 degrees towards me, and you can see the distance between the needle and the vertebra, whether it is coming down or it is increasing. The needle is going near to vertebra or away from vertebra, that we have to check. So I think I am inside, but after turning 30 degree, now here urine is not coming. So I asked the assistant to turn 30 degree, and here after turning 30 degree, you can see that needle is going near to the vertebra. That means we are superficial. So then little adjustment, withdraw the needle till the renal capsule and again reinsert just little deep. So this minor adjustment is important. So now I think I am in, and I asked the assistant to flush the saline. The urine will come. And now we are putting the guide wire. So what guide wire I am using is usually I use 0.35 or 0.38 guide wire. 38 guide wire I use because it is little sturdy, and while doing dilatation, it will not move too much, or it will not have much kinking. Some people will use zebra guide wire, but that is also useful. It is also sturdy, but 38 guide wire, if you have 38 guide wire, 35 guide wire, the need for zebra guide wire is obviated. So after puncture, you can see here I am incising. I have planned around 20 French sheath. So the incision on the skin is now only when the needle is inside, with guide wire is inside. So 20 French dilator, what incision which is required, adequate incision is kept now only. So after the needle, we will put the single step dilator, Teflon dilator is a single step dilator I am using, and we are into the system. And after 14 French, directly the 20 French Mini-perc dilator we are using. So you can see here, single step dilatation. So while doing puncture and dilatation, you should remember that whatever direction which you have used for the puncture, that direction you should remember till your dilatation, because it will help you to go entry the pelvic system very easily. If you forget that direction, you will be going anterior or posterior. At that time, the kinking of the guide wire will be there. So you should remember what is the direction, what is the angle with which you have punctured the kidney. That angle till the end, till the putting the scope is very important, and that you should remember. So here the sheath is placed. Here the screwing movements, you just slide the sheath over the dilator, 20 French dilator. Ask assistant, here important step is ask assistant to flush with the saline once you are taking out the dilator. At this time, specifically for Mini-perc, there will be little bloody field. So if you flush with the saline from below around 10 to 20 cc, all the clots, whatever the clots, blood will come out and our vision will be very clear. So here the nephroscope is placed inside. See, you are visualizing the stone. See the rotatory movement. With the rotatory movement of the sheath, you can go inside the pelvic system till the stone it is. And with the help of either laser or lithoclast, we can break the stones. So once the small, these sizable fragments are there, you can remove with the forceps or grasper, tri-prong forceps. Otherwise, you just advance the sheath uh, till the stone fragments are smaller fragments are there, and with the help of ask somebody to flush the saline from below or little pressure from above, so that the all stone fragments will come out very easily without any grasper. So this vacuum cleaner effect, you can see here, the fragments are coming out of its own. Just advance the sheath till the fragments. Now, once the stone is cleared, you place a guide wire inside the ureter or pelvic system. And once the visible stone is cleared, we have to withdraw the sheath. So once we are withdrawing the sheath, at that time we may lose the track. So this is very important to put a guide wire, place guide wire beforehand, so that we should not lose the track while coming out. So sometimes some stone fragments are in the upper calyx or just above the sheath, some are below the sheath. So to visualize those fragments, secure the guide wire first. This is very important. So here we have secured the guide wire. We are parking the guide wire and we are going by the side of the guide wire. And now, after inspecting the pelvis, we are coming back to see other calyces, so that there is any residual fragments are there or not. And here we have to check whether we are on the floor where complete clearance is there or not. And then the digested placement. So while putting the stent, the guide wire should be there by the side. And if you want to put nephrostomy or infant feeding tube as a nephrostomy, this guide wire is helpful. It will directly go into the pelvic system. So after that, we check for the residuals. And how you check? You just move the ampla sheath under fluoro and see if any radiopaque shadow is there or not. Sometimes if it is a radiolucent stone, we have placed the secured guide wire. Just put an ampla sheath or the 20 French Mini-perc dilator inside, and ask assistant to put contrast from below from the ureteric catheter. So that will delineate the pelvic system, and any radiopaque density it is there or radiolucent or filling defect is there, we can check with the nephroscope or fluoro. So coming to the advantages of the prone PCNL. So prone PCNL, it has better access to the kidney. It provides direct access to the pelvic system, and it allows easier and effective insertion of instrument kidney, and access to the upper ureter is better with the prone PCNL. Second thing is it reduces the risk of organ injury, avoiding adjacent organ like colon, liver, spleen, which are more vulnerable during supine position. Specifically, if you stick to the landmark, like you should not cross the posterior axial line. If you are more posterior to the posterior axial line, then the risk of organ injury is minimized. And enhanced stone clearance, especially for staghorn stone. It is difficult for doing staghorn stone during supine PCNL. This access is very easy. If you have multicalycial stones, then we can puncture under fluoro guidance directly in the prone position very easily. Again, important is horseshoe kidney is very easily done with the in the prone PCNL, because in horseshoe kidney the access will be more posterior. All horseshoe kidney puncture will be infracostal. They are more posterior. They will be through muscle, and majority of time we access the upper calyx of the horseshoe kidney, because they are low-lying kidney. If you access the posterior calyx through medialized puncture, which is through the muscles, then majority of the calyces or majority of the stone can be cleared through that upper calyceal puncture. Again, the upper calyceal supracostal puncture can be easily done in the prone PCNL. So again, better surgeon according to potentially leading to the shorter operative time and reduced fatigue and low risk of vascular injury. As I told you, the posterior approach avoids many of the vascular structures which are found anteriorly, as the broader line which we have seen. The posterior segmental artery crossing is more on the anterior calyx and infundibula. So this minimizes the antravascular injury. All surgeries which we do in the urology, we see from above down. So it's always better to do prone PCNL. and it has been practiced so many years. So the choice of the patient positioning ultimately depend on the individual patient, stone characteristic, and surgeon's preference. There are certain disadvantages to prone PCNL also. We cannot do ECIRS, and each stone has to be removed with the grasper. Unlike the supine PCNL, where the some stones will come with the irrigation or come by the gravity, and additional armamentarium like suction and or shock pulse because is required, because since dust settle down into the pieces, unlike the supine PCNL, where the dust will come out with the gravity or irrigation. So coming to the complications, like there are certain complications inherent to the PCNL, intra-op complications like hemorrhage, which is 1 to 5% cases, sepsis, because if it is infected stone, organ injuries like injured like pleura, lung with possibility of pneumothorax, hemothorax, hydropneumothorax. If you puncture above specifically 10th rib, duodenum, colon injury, abdominal injury like liver, spleen if they are enlarged. Another complication intra-op is hypothermia if you use the staghorn stone, specifically if you are continuing the surgery for 2 hours, 3 hours. The water, and we are using a continuous AC into the OT, so that will lead to hypothermia because of the continuous the cold irrigation. Extravasation and fluid overload if the surgeries are prolonged for a long time. Then coming to the delayed complications. So delayed hemorrhage after 7 days, there is a formation of AV malformations, AV fistula, then delayed hemorrhage patient can present. Sometimes because of infection, there may be some bleeding can occur. This can present after 7 to 10 days or 1 month. Then uretropelvic junction obstruction of positive, if the stone is impacted, and if the sometimes laser has been used nowadays commonly, so this will lead to delayed complications of PUG obstructions or operative stricture. Infundibulum stenosis, if there is a tear while doing the dilatation, if the infundibulum is small, like what we have shown in the Mini-perc case, if you would have used the standard PCNL for that case, infundibulum must have been torn at that time. So that in future that may lead to infundibular stenosis. Nephrocutaneous fistula, if the continuous urine is coming from the PCN tract, then we should think of some distal obstruction like stone has blocking the stent or the ureter. Sometimes some clot might have blocked the ureter, so that lead to continuous seepage of the urine through the puncture site. So in that case, we have to check the residual stone, and in that case, we have to put the catheter so that it will decompress continuously. Perinephric hematoma is another complication which is delayed. Perinephric urinoma and abscess, these are delayed complications which we have to tackle. So these are the inherent complications of the PCNL. So I would like to stop here.
Is it done?
Yes, sir.
Yeah. So let's have a quick presentation, crisp.
Yeah.
So we'll have some basic questions.
Yes.
See, bull's eye, people say that absolute scientific puncture.
Yes, sir.
You can just put over the calyx, do in 30-degree rotate.
Yes, sir.
And make it a point bullseye, and then puncture directly, you will reach the calyx.
Right.
No assumptions.
Yes, sir.
Whereas many people do triangulation.
Yes, sir.
In triangulation, so many A, B, C, D, depth, these, that, they will say.
Yes, sir.
When you come onto the table, you don't remember all that.
Yes, sir.
Only those mathematicians, if they are doing, they can apply, but routinely it is not practiced.
Yes, sir.
So entry point when the patient is lying on the back, imagine inferior calyx or middle calyx, you are going. Okay. Entry point is not defined. It's a clinical judgment.
Yes, sir.
Primarily, it depends on the obesity of the patient, anterior-posterior depth. Right. So, what is your, for example, everybody keeps in line with the stone, infundibulum and calyx, naturally. Correct. Yes, sir. That there is no doubt, no? Yes, sir. After that, you decide one point where you cut with the blade. Yes, sir. Any suggestion? Definitely it is blind. Yeah. Nobody can say, yes, if I go from here, I am the shortest distance or longest distance or safest distance. Yes. Ultrasound is the best. Right. But nobody uses ultrasound because in India, ultrasound is not frequently used. So let me be practical. Question 1. Yeah. Do you take a rib position or finger bridge position or a rough judgment? How do you say entry point? After that, medial rotation, then depth increase. But primary point you don't change now.
Yes, sir.
How do you decide the primary point?
So our primary point will be just, if it is a lower calyx, it will be generally in the just below the 12th rib and posterior to the posterior axial line. That area we should mark. Generally, I ask residents to mark this 12th rib and posterior axial line, and at that area, or that is circle or square, what you can see just below the 12th rib and posterior to the posterior axial line is the area where you can go. If you are
Okay.
planning for middle puncture or upper calyx puncture, in between 11th and 12th rib you can go, but it should be posterior to posterior axial line.
Yeah. So what I personally feel is this may vary a little bit because of the obesity.
Yes.
What is that is correct. 12th rib is even in supine PCNL.
Yes, sir.
I feel that
Right.
12th rib and posterior axillary line and keeping posterior to that is very, very important landmark. I completely agree with that. 1 centimeter here and there does not make any difference. You can adjust.
Right.
If you wanted to go upper calyx, better to go a little away.
Yes.
If you are having only lower calyx, straight onto it, little
Right.
angulated, no problem.
Yes.
So that totally totally depends on the which stone you are doing. This is the first question. So posterior axial line and 12th rib tip below are very constant places where you start puncture.
Yes, sir.
Second question, you puncture the posterior calyx. Generally, we inject the contrast. The one which settles early is the anterior calyx.
Right.
One which dilute is posterior calyx.
Right.
So you agree with this, or you have something else in your mind like gas or Sampio classification, something, or you follow this?
No, I follow this.
You follow carefully while injecting the RGP?
Yes.
What dilution you use in the contrast?
1:3 to 1:5, sir.
More than half dilution?
Yes, sir.
More than half dilution.
Yes, sir.
Okay. So this is the second question. Third question is, when you puncture with the needle, what I observe, because now I am doing supine more.
Right.
17 years I have done prone. Supine, I am feeling that there are a lot of problems in supine except puncture. Puncture is movement of the kidney and movement of the calyx is very much obvious.
Yes.
It moves away and the calyx dimples, and then you know that you are going to puncture.
Counter pressure.
A counter pressure is not there. So in prone, do you think that the kidney and calyx move that much, or you have to go only by C-arm characteristics?
No, that much movement as the supine is not there.
Not there.
We just jiggle the move with the jiggling movement. We just see feel the thoracolumbar fascia, feel the calyx, the renal capsule, feel the calyx, and then enter. So jiggling.
I agree. What exactly I wanted is that jiggling movement. You correctly told.
Yeah.
What I wanted is whether it is supine PCNL or prone PCNL, if you move a little bit front and back, not holding the needle very stiff, you can feel that what layers you are going.
Right, sir.
And don't change the direction of the needle when you are going.
Right.
It's correct. Yeah. That exactly jiggling movement I want. Front and back little bit of movements before entering to the calyx is very important. There itself you can adjust 10 degree up and down.
Yes, sir.
Do you agree or not?
Yeah, absolutely.
Yeah. Next question. After a perfect puncture, you have seen 0 degree, you have seen 30 degree, again 0 degree, again 30 degree, especially in a non-dilated system. If the guide wire is not going, if the water is not coming, especially in the middle calyx, if obstructed system is there, force transmitted is not coming for various reasons. If the water is not coming, and you have tried enough times and guide wire is not passing, and you 5 times Mankej out, you have tried, you not a system very dilated, and contrast also not leaked.
Okay.
That means you have not punctured.
Yeah.
then your all applications will be going. Basic ABCD that 0, 30, 0, 30. What are the extra tricks you follow? I hope you understand the question.
Yeah, I understood. So we need to change the entry point.
Okay.
Sometimes the entry point which we are using, which we are doing, that is not going properly. So we
Correct.
have to change the entry point. Sometimes we have to change the calyx, targeted calyx.
Calyx also.
Yeah.
Yes.
So then we can go ahead.
So
But
even if absolute scientific puncture is done and if you are failing, don't unnecessarily keep on banging the same calyx and the same entry point. Change the entry point, change the calyx,
right.
which can give access to the stone. Absolutely no harm. Most often you will succeed.
Yes.
Most often you will succeed.
Yes.
My sixth question. If you puncture the anterior calyx, what are the signs which say that you may be in trouble today? By chance, you don't know anterior, posterior, equal contrast seen, quite lateral calyx. You felt happy to puncture lateral calyx, but unfortunately, it is anterior calyx. What are the, while puncturing, while passing guide wire, while dilatation, what are the points on the C-arm you feel that I am not comfortable?
So first of all, sometimes we will have difficulty in puncturing calyx. So anterior calyx is punctured. So putting guide or passing guide wire into the pelvic calyx system will be difficult.
Okay.
And even if you pass the guide wire, then dilatation will be difficult. While doing dilatation, the kinking of the guide wire, the straight path will not be there.
Yeah.
So sometime even you dilate this with the single step dilator, then amplus dilator, that will tear the pelvic calyx system. Sometime bleeding, or like you can see the fat if you pass an endoscope or this nephroscope. So these are the points where we can see the bleeding and extravasation. These are the commonly seen if you not puncture desired calyx or anterior calyx.
Right. So one more thing is that smooth curve of the guide wire
Into the
into the ureter or wherever will not be there.
Right.
A little bit bend down and then goes like this.
Yes, sir.
Whenever you withdraw also, it doesn't straighten.
Right.
In
Yes.
posterior calyx, if you withdraw a little bit, somehow it adjusts and make a smooth curve.
Yes, sir.
That also will not come in anterior calyx.
Yes, sir.
Next one, very important question, practical question. Answer with your wiseness.
Yes.
I have seen when you go in PCNL inside,
Hmm.
suddenly if you see fat, you think that you have perforated, but it is only submucosal region.
Okay.
Entire kidney you cannot perforate to see the fat.
Yes, sir.
Appearance will not be like parenchyma, it will always like a loose fat.
Right.
Why like that? See, you have not done through and through perforation of the kidney.
Right.
Even small perforation looks, if you go deep, as if you have gone into the outside the kidney. Is it really outside the kidney? When you inject contrast, it won't extravasate that much.
Now, this is because the parenchyma, because of the continuous saline, the saline seepage into the parenchyma, that will look like a fat inside. Yeah.
This
Because
always we fear, but that much fear is not required if the bleeding is not there.
Yes, sir.
You agree or not?
Yeah,
You can readjust a little bit and then go.
Right, sir. And finish
It's
the
not
case.
exactly total kidney is perforated. It's not possible to perforate that.
Yes, sir.
Yeah.
Finish
Next question. So in the water seepage may change the look is your answer. I don't know the answer, but I'm asking you.
Yes, sir.
Next one. If you have punctured the system and guide wire has not gone and you removed the needle and suddenly a lot of contrast leaks outside and makes system little bit hazy. Somebody might have pushed more. As you said, instead of 50% contrast, they used thick contrast. Perinephric region all gets blurred. That calyx, which is very important to that stone, gets blurred. It happens sometimes in conferences, disaster. After that, God only has to save to reach that calyx. And if you want to puncture another calyx, you may not reach the stone.
Right.
A long infundibulum like this, imagine. Long infundibulum, some posterior calycial stone of 1.5 centimeter, entire thing got disturbed.
Yes.
And unfortunately, thick contrast is used. What to do then? Don't
So
think I'm asking tricky questions.
no,
Together we are sharing. This is a common problem. Don't think that I'm testing your knowledge. No. It is exchange of the knowledge where it's a difficult situation for you, for me, anybody, as a matter of fact.
right.
How we can think in that angle?
So first thing is that if you have availability of ultrasound, you can do ultrasound guided puncture.
Correct. Very good answer. Ultrasound will not show all this contrast.
Yes, sir.
Small amount of contrast.
Yes, sir.
That is an excellent answer.
The second thing is that we again where was the calyx initially? That calyx we need to puncture. So this 30-degree help in to identify precisely the location of the calyx. So suppose we have punctured the desired calyx, we have gone. We are not sure whether we are in the system or not, and ask the technician to do 30-degree. If the distance is remaining constant, then apparently we are in the pelvic calyceus system. That is the second. And third will be we need to puncture the other calyx. This is the another option.
Yeah.
So,
Other calyx we are not talking, because other calyx is a totally different story. What
okay.
I was thinking, ultrasound is the correct one.
Hmm.
I think every time we have to remember where we are in relation to the rib, paraspinal region, everything, so that sometimes, if you are lucky, as you said, in 30-degree, you can hit the stone, and in the midst of that contrast, you hit once again. By chance, if you hit the stone, job is done.
Right.
That's why I told 1.5 centimeter. You have to remember area in relation to the rib, in relation to your body, and your depth, if you remember, because you already punctured. Yeah. Unfortunately, something wrong has happened. Yes. But prevention is better, as you said, 50% to say 60% dilute contrast is better.
Right.
Now, coming to the Krishnamurti has asked from Karimnagar, supracostal puncture you have not covered. In supracostal puncture, in prone PCNL, would you like to puncture lateral one always, or you don't mind going to the most posterior calyx, even if it is superior? Posterior, superior is your choice, or lateral, whatever calyx is your choice to avoid the supracostality?
Lateral calyx is a choice because vascularity is more on the medial and anterior. So remember, anterior and medial calyces have a vascularity, vessels run over the infundibula. So the lateral is the choice, and from lateral we can negotiate to medial also. If you access the lateral properly.
In supine, we follow only lateral.
Yes, sir.
No choice.
Yes, sir.
Prone also, we try to be lateral because it is a compound calyx.
Right.
And what absolute anterior, absolute posterior will not be there.
Yes.
A long infundibulum will not be there.
Right.
And instead of unnecessarily taking panga with the superior medial, which needle may go and hit the infundibulum, so go laterally parallel and then manipulate afterwards. Right. But this is not applicable for the stone in the inferior calyx, where if you have to supposed to remove, then turning will become difficult. That is the only. That's why you mentioned in the beginning only that we are used to inferior calyx more, and I feel 90% of the prone PCNL surgeon first try to get everything through the lower calyx because torrential complications. But logically, because the superior calyx is more posterior, you can access to all parts of the kidney. If you go medial posterior calyx, if you properly get it, sometimes huge staghorns can be removed through that. Right. But there is always a risk of, if you go deep, infundibular injury, or anteriorly going is not good anyway. Yes. Next, in bifid system, if you are doing prone PCNL, if the stone is there in the upper calyx, and I think you might be doing RIRS, honestly, 1.5 centimeter stone bifid system, upper calyx, supracostal is coming. You prefer RIRS or PCNL?
If it is they depend upon the infundibular width.
Good width.
good width, then we can plan for
So for RIRS.
RIS.
If RIRS is not option and you wanted to do prone PCNL,
Hmm.
do you make an oblique tract upwards towards the upper calyx and get the stone out, or you try to be nearest tract?
Nearest tract.
Some people do from the middle part of the kidney to the upper pole,
No.
travel a Brodell's line long length, nothing will happen and take out the stone safely than supracostal. What is your opinion?
We'll go like transverse tract will be there. Like we'll put either supracostal in between 10th or 11th rib, posterior to
Yeah.
posterior axial line. The transverse tract, not the completely oblique tract. It will be a little transverse only.
Transverse tract. So going above the calyx, going above the 10th rib is not advisable.
Not at all.
Not worth.
Not at all.
Not worth. A lot of people don't recommend that. Better
If
go either horizontally or worth 10-15 degrees down up also okay. Not like middle pole.
Yes,
In
sir.
the upper pole only try to select from the 12th, 11th rib below, not above the 11th rib.
Yes.
Yeah. I also do all cases under GA. But for your kind information, in North India, when I discuss,
Spine.
they say that we never do under GSR, we do under spinal.
Yes, sir.
I don't know if the respiratory movement is there. It is annoying to hit the calyx. It needs more technical skill. As a matter of fact, in South India also, there is no regional difference. Those cases where Arogyashri or Yojana scheme are there, when they wanted to do under low cost, what do you think the respiratory effort, can the patient stop respiration and do puncture once the kidney comes down? Do you have experience? In Nadiad, they don't do under spinal?
Yeah, they don't do under spinal, but we used to go for camp in periphery and we used to do under spinal only. So we asked the patient to hold the breath while doing puncture and dilatation. And then once we are in, then he can have his respiration.
Yes. So it is slightly difficult, I feel.
Comfortable level of surgeon is not good.
Comfortable level of the surgeon is not there. Definitely, I feel, I am, in fact, rare that I do under spinal, even RIRS,
Yes.
because clearance, dilatation, everything is under your control.
Yes, sir.
Last couple of questions. If ultrasound is not available,
Okay.
if contrast doesn't go into the kidney, what is your tips and tricks to get the system delineated with contrast initially?
So we need to do stone guided puncture or
Stone guided, if it is in pelvis, we cannot do.
okay. So
Imagine if it's not a peripheral large stone.
yes,
If
yes.
you wanted to get water or urine, any blind methods, ultrasound is not there.
Yeah, there are blind methods. We can go for paravertebrally, just go till the adequate depth is there and try to aspirate with the syringe. So we'll hit the pelvis or pelvic calcareous system, and once you are urine, put a contrast there and then do the puncture.
I have seen Ashavardhan repeatedly telling, who is my friend and does good in prone PCNL. He says spinal needle, 12th rib below, again same point box, and go 45 degrees angle towards the stone area, not stone hitting. And then while withdrawing, as you said, this is only put the contrast, not for dilatation, not for anything. This happens actually yearly, thrice, twice. Everybody has to face this. And if he is successful, very happy. We feel very happy that you have done the case.
Yes.
If you are not successful, it's annoying. Coming out of the theater, not doing anything, it's very, very difficult. You can't attempt blindly more than 10 attempts. So ultrasound has a major role.
Yes, sir.
Last question. Being from Nadiad, do you recommend in the future, where India is practicing PCNL with a lot of experience, can't imagine some amount of PCNL done in periphery, even we might have not done that amount of risk in districts and taluks, juniors will be doing, but they don't know ultrasound.
Yes.
Will that change ever come in Indian scenario? That this is the last question. That every case, now after buying the BK, I'm telling you, it will be there almost in every case. Soundarya is particular about that. and she is knowledgeable. Every case they put entry point, decide and remove it. Rest all do with the supine PCNL, I mean to say. These
Okay.
are free purpose.
Okay.
At the same time, ultrasound has lot many advantages. What is your opinion in prone PCNL, role of ultrasound, in your experience after the MCH completed, DNB completed?
Role of ultrasound, as I told you, as you told, sir, when there is a no feeling of contrast after putting a contrast into
So
the
routine cases you don't mind,
routine cases not required and
not required.
required.
Why
Accessibility.
Mahesh Desai sir says, I always puncture under ultrasound. Is it true? I mean, mostly it is true.
Yeah, it is
He
true.
always punctures with ultrasound. He says that that is the way. Even Sabni sir supports that.
Yes, sir. But the availability and accessibility and training into the ultrasound is
It's
important.
difficult.
Yeah, because availability, accessibility, if you have, still you don't have training of proper puncture, then it is worthless.
Sure.
So these three.
So that is the, I appreciate your simplicity more than anything else. You are very, very simple in your presentation, and you are very crisp. Crisp and simplicity reflected very much. This subject will be discussed for years, and it will be there.
Yes.
PCNL, it will be there in stone management forever is my feeling. After 100 years also it will be there.
Yes.
Prone PCNL will be there. Without knowing prone PCNL, private practice is impossible. Even government practice is also impossible.
Yes.
Very well summarized. Supracostal you might have covered, but next time we will cover one supracostal.